Do we have an underdiagnosis disaster with respect to sleep disordered breathing? Is it true that 90% of sleep disordered breathing is undiagnosed?
Yes, I'd say at least. I mean, it's at some level, almost everyone has some level of sleep disordered breathing. If you look at the ICSD, International Classification of Sleep Disorders, they define sleep apnea as an AHI of greater than 5. And I'm sure your audience is familiar with an AHI. But they also define an RDI greater than 5 as positive for sleep apnea with symptoms, which almost everyone has some symptoms. And if you go by RDI, the prevalence is extraordinarily high. And most ENT physicians, maxillofacial surgeons, they focus on AHI.
Mm-hmm. While you mentioned the distinction between AHI and RDI, perhaps you could dive into that. I think sleep testing is one of the more technical aspects of this space that's not intuitive. Would you mind, as if you were speaking to a fourth grader, distinguishing between AHI, RDI, apneas, in RERAs, and the other sort of jargon that's important to understanding sleep testing?
Sure. AHI stands for Apnea Hypopnea Index. I'm not sure if this is catered to a fourth grader, but an apnea is defined as a 90% or greater reduction in airway. So if you take a straw and you pinch it off 90% or more, that's considered an apnea. A hypopnea is considered 30% or more reduction in the airways, and take a straw and pinch it by 30%. And I means index per hour. So and the hypopnea in the AHI has to be associated with either an arousal, which means the brain wakes up, or a drop in oxygen of 3% or 4%, depending on the criteria people use. And typically, an AHI between 0 and 4.9 is normal. Between 5 and 15 is mild. Between 15 and 30 is moderate, and 30 and above is severe. An RDI is a respiratory disturbance index, and it subsumes all of the AHI. It includes the entire AHI, but it also says that you can have interruptions in breathing, that aren't as significant, but they still cause an arousal of the brain. And so, how I look at it is, and perhaps I'm simplifying, but it seems like in the lay world, what's happening is an AHI is just linked to the DSATs, the drops in oxygen, and the RDIs are more linked to the arousals, where there should be arousals included in the AHI also. It's easier, at least for some labs, not to score the arousals because it's more difficult. The software can score drops in oxygen very easily, versus having to score arousals requires, like hand scoring. In any case, the point I'm making is, if you simplify it, you can think of an AHI as being linked to drops in oxygen, and an RDI linked to more arousals. And an AHI, if you want to think of it this way, can be linked to more of the physiological problems like high blood pressure, heart attacks, strokes, and whatnot. And maybe an RDI is more linked to the behavioral symptoms like, anxiety, depression, ADHD, brain fog, things of that nature.
Is it also the case that a young person who's physically fit, let's say of healthy weight and fitness, might have a high RDI but not a high AHI? And so we could say generally that using the AHI as a litmus test for determining whether someone has sleep disordered breathing is not the best, because it leads to a lot of false negatives for younger people like myself that might take a sleep test.
Absolutely. The AHI, well, as I said earlier, the official diagnosis for sleep apnea includes the RDI greater than 5.
Right.
But the reality is, a lot of people just don't follow that rule, or not even aware of that rule. And insurance companies demand an AHI greater than 15 for approving procedures. So absolutely, that's why it's underdiagnosed. The RDI is not looked upon or even understood, first of all, and secondly accepted.
Mm-hmm. And the reason that younger, fitter people might not get actual apneas where their blood oxygen drops below that threshold? Is it because they're sort of like fit enough to essentially adjust their bodies when a sleep disturbance is happening before the blood oxygen has a chance to drop that much? Or is that not actually the mechanism of why younger people don't actually get apneas?
I don't know. We know the answer to that. I can tell you, I have a lot of young people with apneas, but
Okay.
I understand your point that maybe a lot of them may not. But I see young patients with apnea too. It's really, and I do think the younger you are, potentially the tone is better. You have
Hmm.
less, like when you infiltrate, like the airway is just a flexible tube. There's no bone that holds it open. And when you infiltrate tissue with fat, it becomes more collapsible.
Hmm.
And it could be that what you just said, when you're young and fit, you don't have as much collapsibility of your airway. And therefore you get more arousals than desats.
Is it the case that mainstream sleep medicine is not really up to speed on the importance of testing for RERAs, in that, generally speaking, there are too many false negatives of people who take sleep tests?
Yeah, that's why, I actually like, unless I do the overnight sleep study, with the comprehensive overnight study, I actually prefer a watchpad study. And the reality is, I don't, because at other labs, I don't know who's running the test, more importantly, who's scoring the test, what type of equipment they're using. I mean, for instance, an arousal, sometimes you see an arousal on the central leads, sometimes you see it in the frontal leads, sometimes you see it in the parietal leads. It's not always, necessarily obvious where the arousal is. And you have to hand score it. And different softwares have different levels of accuracy for scoring. And now I think there's been 2 products that have been officially approved for automated AI scoring, but even how they have to be conservative at the end. So it's, and most labs do 10, 15 studies a night, and so unless you really go through and you use the best equipment and you hand score it, I don't know. I'd rather use a watchpad for patients. I
Hmm.
mean, coming from elsewhere.
What is it about the watch pat that makes it better for avoiding these false negatives?
Well, I mean, the watch pad has a lot of variability too, but part of the reason is there's also variability in your night to night sleeping. As you're aware, if you, do a sleep test 5 nights in a row, you're going to get 5 different results, hopefully similar. But the watch pad uses peripheral arterial tonometry. And so, I mean, in lieu of a cortical arousal, every time you have a respiratory event, your heart rate goes up, your blood pressure goes up, and your arterioles constrict, and the watch pad detects it. So it's highly sensitive. It's better than any home sleep test. Among home sleep tests, it's better than any home sleep test with the belts, because the belts are notoriously, they're ill-fitting, they come off, and may not be secure enough
Hmm.
to register.
What is this that I hear about the so-called PES monitor, the pressure in the esophagus monitor, that's used to help connect uh, neurological disturbances with uh, changes in breathing? Is that important to be able to connect those two things as someone who's analyzing a sleep test to make sure that you understand that this neurological disturbance is related to some sort of airway issue?
I mean, I'm assuming you're referring to the esophageal pressure manometry, the PES.
Yes. Yes.
Yeah, we did that for I mean, I don't do it anymore, but I did that for over 20 years, about 20 years. And what the PES is you put a catheter through the nose down into the esophagus, and it measures basically the suction pressure, the negative pressure. And so the theory is that when you have an obstructive event, prior to the obstructive event and the arousal, prior to the arousal or the drop in oxygen, you have an increase in negative pressure. And versus a central apnea, where the brain turns off the breathing, so to speak, there's no change in that effort, so to speak. So it's a measure of effort or negative inspiratory pressure. And it is helpful. It actually is helpful to see that. It's pretty fascinating to see the extra effort go and then the effort resolve, the resistance, the negative inspiratory pressure would normalize after the arousal or desat and the apnea is terminated. But but there's some few problems with the PEZ. Number one, it's uncomfortable. You have this thing through your nose and it's in your esophagus, right? Number two, in about 10% of the patients, the PEZ actually stents the airway open. So when you would actually have sleep disordered breathing, it'll normalize it because you basically inserted a stent into your airway. But I think in the situations where it would be helpful is when you have a lot of hypopneas, just hypopneas, and you're worried that it might be central. Now, most of the time, you're not worried it's central. And the reason why it's hard to distinguish, like with an apnea, it's very clear. There's no flow, but there's continued respiratory effort. In a central apnea, there's no flow, but there's no respiratory effort either. And so the chest and abdomen don't move. But if you have a PEZ, for a hypopnea, there's some flow, both obstructive and central, and there's some movement of the chest in this obstructive, in a central or obstructive. So the only way so basically a central hypopnea and obstructive hypopnea look identical. And so the only way to tell them apart would be an esophageal pressure manometry. But I don't think that's really relevant for 99% of people, at least that are listening to your podcast.
The 90% figure that we always hear about, 90% of sleep apnea is undiagnosed. Does that include babies and children? And are infants, children between the age of 2 and 12 months, and then, kids, are they experiencing sleep disordered breathing as well?
They can. I mean, you can get allergies in utero and you can emerge from the womb a mouth breather. As strange as that sounds, right? But, and so it can start quite early. 60% of your face develops by age 4, 90% by age 12. And so, if you can really, I'm sure you're aware of this, but as long as you establish nasal breathing, you control allergies, and and you have good lifestyle and dietary habits, breastfeeding and whatnot, I think you should I think everyone has the potential of developing properly, which means, the forward, outward, and upward growth of the maxilla, the mandible that grows along with it. So I think everyone, and, function and form go together. And so I think everyone has the ability to function perfectly, and everyone has the ability to look beautiful. But somehow along the way, we screw it up.
Yeah, we sure did. Do you ever test babies and children for sleep disordered breathing?
Yeah. I mean, I think the youngest we've tested is like 4 weeks of age. But usually at that age, it's more central apneas that you'll see. And I almost recommend not testing babies because it's kind of scary what they go through. You'll see like 5 or 6 central apneas, and sometimes they'll drop into the 70s or 80s, the percentage, and it's terrifying. And then I track these babies over, and what happens is they all get better. It's almost like the brain develops and they go away. And so I guess I don't know if I would recommend with a new mom getting a sleep study on a baby. I think it would just terrify them to see what they see. But apart from just making sure that they use a lot of saline mist, and they can keep their nose open, and they can sleep with their mouth closed, and the bedding environment is free of anything allergic, like no rugs, keep everything in the room wood, metal, glass, like very hygienic and clean. I think they should technically be okay.
When babies are first born in those first few months, is it also partly that they're just very soft and flimsy, and that the airways get a little bit sturdier after, at age 6 or 7 months, let's say? And so it's almost normal for a baby to struggle breathing in their sleep a little bit in that first couple of months?
I mean, part of it is the brain, like the brain is developing. So you start off with a lot of sleep fragmentation. As you know, a baby wakes up and sleeps. Then you get a consolidated sleep, period. And then as you get older and you start getting sleep fragmentation again. And part of it is due to your neurodegeneration. I think for babies, though, the main thing is that they breastfeed, and because that, that the work of having to, I call it masticatory effort per calorie, like they have to work hard for every calorie versus, using a bottle, there's just no effort, per calorie, right?
Yeah.
So as long as the masticatory effort per calorie is high, that should lead to the forward growth of the face, all in theory, and usually it works out well.
It worked out that way with my daughter, who's now 7 months. When she was first born, her jaws were a little bit recessed, and she had almost like a pug-like snore that she was always doing, like that. But after 7 months of pretty solid breastfeeding, she does do a little bit of bottle, but I would say there's a good amount of breastfeeding that happens. That issue has gone away, and now she's nasal breathing all the time during sleep.
Excellent, congratulations.
Yeah, thank you. I think
Um,
yeah, go ahead.
I think like if you look back to the Native Americans, like, in current Western society, I don't know how it is in your household, right? But you're exhausted with the kid, and as soon as the kid falls asleep, you put them in the crib, they fall asleep, and you're out of there, right? And you're exhausted, and you want your time to alone and whatnot. But really, the Native Americans, what they would do is they would basically like cradle their kids to sleep, and then they would put them in the whatever, crib thing that they had, that they wrap them up in, and then they would stand guard by them at night. And if they needed to,
Wow.
they would just keep their mouth closed. They would just sit there and make sure they breathe through their nose. That was one of their jobs. So I feel like it's a difference between our current society, where they're out, let's see you later, we're gone, and versus standing guard and making sure that they develop the way nature intended.
On that note, another thing I've learned about breastfeeding since having my daughter is that actually most of the breastfeeding happens in the night when my wife is asleep. The baby will just crawl up onto my wife while my wife is asleep and feed in bed with my wife. So you hear a lot about babies, crying in their crib all night. Well, the solution that we found to that is just sort of let the baby jump into bed and let her do her thing with mom all night long if she wants. And yeah, it's tough on mom to some degree, but my wife has got used to it. And I mean, she will be latched for I don't know how long each night, maybe an hour or two each night while my wife is asleep. The baby is latched doing her little thing.
I, it's very controversial, and American Academy of, Pediatrics has all these guidelines of co-sleeping and whatnot. But in my opinion, I think it's natural. We're herd animals. You see packs of dogs sleeping together, right? And that's how probably where our ancestors were. And as long as you don't roll over on your kid, I think everything should be okay.
Yeah, there is that risk, of course, and you have to be super careful. But what I found is that you almost develop an instinct where you sort of sleep with one eye open. You never fully go into that deep sleep where you could mindlessly roll. You're always aware that the baby is there and that you have to be very kind of careful with your movements. But also having a king size bed helps a lot too.
Yes.
So
Well, I'm a fan of I actually think human touch is super important. So I don't think I'm not into the Ferber method of, leaving them and letting them cry it out and whatnot.
oh yeah, the cry it out method. Yeah, I don't know. That's not for us. No,
Yeah.
especially not this young. Um,
Yeah.
my
But
wife does most of the research into the approach we should take, but generally where she lands is something that seems right to me and that seems like the natural traditional way, in the more human way.
yeah, like I said, there's people that swear by all these different methods, but I just go back to what would our ancestors do? What would the hunters and gatherers do? What did they do?
Yeah, I agree. I mean, taking the sort of primal premise to all things health, mental and physical, has been sort of at the heart of what I've been doing for the past 15 years. So I totally agree. Right. I mean, at the end of the day, we evolved. Uh, we come out of this sort of paleo history, And we can always refer back to that for insights as to how we should behave in the modern world, even though the modern world is a very different landscape than it was back then.
Yes, exactly. It's hard because everything is stacked against us right now.
Yeah, how do you mean?
Well, we've moved indoors, and
Mm.
that's not natural. Humans are normally nomadic. We go to a place, we eat the fruit, and hunt the animals. And when it's deprived, when it's gone, we move on to a next location, right? And most of the foods we eat right now are processed foods, or quite a bit of it. It's everywhere. And as I said, the masticatory effort per calorie is substantially reduced, right? And so, or substantially, yeah, substantially reduced. So there's no effort, and yeah, I mean, those are probably the two main things: is the diet and where we live. If you took us right now, if I took you, Ron, and put you out in the wild and said live like a lion, and you had to hunt with your mouth and tear flesh off and eat whatnot, and but vice versa, if I took that lion and brought him into your household and had him eat the foods that you eat, in a few years, what would you look like? And in a few years, what would that lion look like? Would
Yeah.
he still be majestic?
Right, right. This used to be called the zoo human syndrome. Um, there was a guy who ran this website called MoveNat back in the early days of paleo, and he would call this the zoo human syndrome.
Oh,
How
interesting.
people fall apart when you take them out of a natural environment. So I'm totally with you, and it's worth fighting against that. And I think there are ways of being primal in the modern world, right? And I just hope I can do that with my daughter as much as possible, so that she doesn't have some of these terrible airway issues that I've had, and that a lot of the people that I speak to on a regular basis have.
Yes, I'm sure you'll do better than most.
I'm trying, and obviously my wife is the most important factor in that, but she's totally on board. I don't know if you've seen her JawHacks Baby page, but she documents some of her um, experiences with sort of primal raising of the child and giving the child a chance at having decent jaws.
Oh, I'm going to check that out. Actually, I did see her in some of your other videos where you were getting procedures, but I didn't see that, so I'll look it
Yeah,
up.
yeah, it's really good. Getting us a little bit back on track, Doctor. So there's a massive underdiagnosis disaster with sleep disordered breathing. So then, whose job is it to catch sleep disordered breathing? Is it primary care physicians? Is it dentists? Why is there so much underdiagnosis? Whose fault is it?
I think it's lack of awareness, first of all, and they really don't go over it too much in medical school and whatnot. I think the first person that would probably be the most obvious would be the dentist, because they actually look into the mouth and whatnot, or the orthodontist. Um, I think they would be a good first person to catch this issue. I think the primary care doctors and the pediatricians, especially, should catch it. The problem is now I'm not sure if you're aware of this whole insurance is healthcare crisis. The reimbursements are dropping every single year. And so, the administrators need to continue to, make their usual amount. So what they do is they just cut services, and so you have, and so basically doctors and practitioners have less time with each patient. So it's getting worse. Basically it's why are you here, Ron? What hurts, or what can I help you with? It's not, oh, let me look into your entire holistic care and try to figure out something that you may not be aware of or coming to me for. And that's where we're at. And so we're in this insurance-based world that is becoming less and less profitable, requiring you to see more and more people for a shorter amount of time.
That sounds like some sort of death spiral of medicine.
It's a death spiral. Like I think in the insurance world and sleep medicine, you have to see at least two or three people an hour. Otherwise you're not gonna, and what time and that's in sleep medicine. In primary care, you barely have 10, 15 minutes with your doctor.
Wow. Is the problem that we don't have enough doctors, or is there some other problem? Do you think if medical school were a little bit less expensive and a little bit structured differently to allow more people to become specialists without, hundreds of thousands in debt and, you know, 10 years of formal education, and they then we could have more of them who could be seeing more patients at less, for less money? Is that part of the issue or not really?
Um, it's hard to say. I mean, I think that's a pretty macro question that you asked. I'm not sure what the solution is, but yes, we don't have enough practitioners, and they are using, like, you'll notice that when you go to the doctor now, a lot of times there's nurse practitioners or physician assistants that they're booking you with.
Right.
So it is getting addressed, and now one doctor can oversee multiple nurse practitioners or physician assistants.
Hmm.
And so that's how they're getting around it.
Hmm. Hmm. That's pretty upsetting.
Like a
What?
lot of places, the sleep medicine doctor may see the patient initially in some of these larger organizations, then they pass it along to the nurse practitioner. And they just see the initial consult, and all the follow-up and everything else is done by them.
Mhm. Yeah, it's no wonder then that channels like mine have gotten popular, because I think the position this puts patients in is that they have to rely on sort of self-diagnosis, and they have to really be their own advocate in order to make sure that they don't fall through the cracks.
Exactly. Yeah,
But
and you have to um, somehow reach your voice to the mental health side, the psychiatry patients, the ones with anxiety, depression, ADHD. You have to reach out to the neurologic side, to the ones with brain fog and poor mental acuity, forgetfulness, almost like early dementia-like symptoms, and any type of neurodegeneration. So anyway, it's a broad audience that you have to reach out to.
right. And are you talking, those are sort of the types of people you might encounter in a sleep clinic, or people with psychiatric issues and then people with sort of neurodegenerative issues? What was the point you were just making?
Okay. Well, the point I'm making is that I'm not sure if your audience has heard this before, but sleep apnea is, you have to think of it as a traumatic brain injury.
Hmm.
Every arousal, every time you wake up, every time you have a DSAT, it's like a little mini concussion. And you can have 5, 10, 15, 20 an hour. And you can do that for months, years, decades. And, like I always tell patients, there's a hidden order, the horizontal thirds, the vertical fifths. There's a hidden order to everything. When you have that order, you look good and you function well. And when that order is disturbed, that's when you can get anxious and depressed and ADD-ish and unfocused and forgetful and sleep poorly and be tired and yawn and whatnot. And so, yeah, so if you have sleep disorder breathing, you most likely have some element of, I don't know, I don't sound like hyperbole, but brain damage.
Hmm.
and and what's fascinating about, like, even your channel, I would say that there's a lot of focus on uh, stopping it. Hey, let's put you on CPAP. Let's get the palate expansion. Let's do an advancement. Let's do nasal surgery, and which is the best one, whatnot. And all that does is it stops it. But there's no guarantee that the brain restores itself. A brain that fires together, wires together. It's like working at the I don't know, in California, the DMV. It's like working there for 20 years. And then you go to a startup. I don't know if you've ever been to the DMV, but long lines,
Of
everything is slow
course.
as glasses, right? And
It's
then
miserable.
you go
Yeah.
to a startup. But are you going to be quick and nimble and whatnot? Or are you going to have that DMV mentality wired in? And so I always tell patients, hey, part of it is to stop what's damaging your brain. And then the other half is try to restore the brain. And that's why also I'm sure your audience, some of them have gone through palate expansion. They have gone through MMA. They have gone through nasal surgery and myofunctional therapy and you name it. They've been through everything, but they're still symptomatic.
Hmm. And when you say they're still symptomatic, they might not be symptomatic with respect to AHI or RDI, but they're symptomatic with respect to the indirect symptoms that come out of sleep disordered breathing, like
Exactly.
depression, anxiety, brain fog.
Yeah, exactly.
Wow. So, what are some auxiliary treatments that need to be done for someone who's been dealing with this for 10 or 15 or 20 years? You're saying that perhaps psychiatry or other such therapies to help you rewire your brain into a healthier direction are called for, and is that something you help transition patients into or hand them off to after you diagnose sleep disordered breathing?
Well, I mean, I guide them. It seems like it's the epidemic is, it's an epidemic of things that slow your brain down. And for instance, like just this computer screen, if us taking a walk for 15 minutes versus staring at a computer, it shuts your brain down. And every time you shut your brain down, a brain that fires together wires together. All the
Right.
antidepressants, the majority of them, serotonin, you have to ask yourself, is it an excitatory neurotransmitter or is it an inhibitory neurotransmitter? Well, Prozac, Celexa, Lexapro, even the SNRIs, Cymbalta, Prestige, whatnot. The serotonin component will slow the brain down, and you take those for years, like many of your subscribers, I'm sure, are on, and it slows the brain down. Sleep apnea, like I said, it's a mini concussion. When you get hit, your brain, it slows down a little bit.
Right.
And so I'm very conscientious about when patients come in, and so I look to see what else they're doing, and I try to speed up their brains.
Right. Right. While we're on that subject, what are your thoughts on cannabis? Is that something that retards the brain and slows it down, or is that something that stimulates the brain?
Oh, I used to think it was innocent. I thought THC was not a big deal, right? Everyone's really relaxed. But you know how the person looks slow? They look like they're
Sort of
just so
droopy.
relaxed. Well, it shows up in the brain that way too. Absolutely, categorically, it slows the brain down.
Hmm. Hmm.
And
So,
I was always, prior to mapping someone's brain, I didn't think too much of it, but I would get people off the cannabis if I could.
it's just another tidal wave of slowing the brain down in current culture, and especially in younger people. That a lot of my audience, I think, because I think the thing about cannabis is that initially it feels like it's a stimulant and it feels like it makes you sharper and more motivated and excited, like during that peak of the high. But then in the wake of that, it just really numbs the brain. It kills the short-term memory, so that the experiences that you had when you were on cannabis, they don't even get registered to some degree. So in some sense, it didn't even really happen because it's not being logged in your memory. Um, and I think it's a big trap that young people are falling into.
Yeah, I think one thing that we have to be, and this is really, I'm not, this is kind of like getting a little bit further, but it's on topic. What you have to realize is that you do things for a reason. Your subscribers are doing things for a reason. They're taking that antidepressant for a reason. They're smoking pot for a reason.
Mm-hmm.
And when you're, just like if you don't have the proper horizontal thirds, you don't have the proper vertical fifths, you suffer, you have consequences from it, and then you do things for it. You may drink coffee and whatnot, right, to make up for the sleep disorder breathing. Well, the same thing with the brain. When you have an imbalanced brain is balanced with an imbalanced lifestyle. So when you don't have order up there, that's when you're going to smoke the cannabis. That's when you're going to grab that drink of wine or a glass of wine. That's when you're going to take that antidepressant, or you're seeking something, right? But you can't just stop it. You can't just, hey, stop the pot, because you need it. It's almost like a bad relationship, like a domestic violence relationship.
Right. Right. There's an allure to it.
And so what you want to do is try to reorder the brain. And if you have a good order of the brain, you can have, like, if someone is really ordered well, you can hand that person pot. They'll say, I don't want it. I mean, you may do it for fun, but doesn't need it. Here's a glass of wine. Yeah, I don't need it. Here's an antidepressant. I don't want that.
Right. Because they're already feeling good. Why fix what's not
They're
broken?
already feeling good.
Mm, mm. Yeah. So just to sum up this portion of the interview, doctor, broadly speaking, what can we say the impact of underdiagnosis of sleep disordered breathing is having on the healthcare system?
I think it's pervasive in that it has a hand in almost any specialty you can think of. And I won't. And the problem is, I think the macro climate for healthcare is one that they're going to address it less, not more. Like Anthem, I believe it's Anthem. I don't want to say the wrong. They just came out with their new guidelines for CPAP, and now they're saying we don't pay for it if it's a 3% DSAT. It has to be the 4% Medicare DSAT criteria that we're going to pay for. So they're getting cheaper.
Wow. But
It's not a direction.
don't they understand though that long term that's just going to lead to more health costs in the future? Or do they think too short term? Is this a sort of a greedy capitalist short term thinking thing, or are they
I think
ignorant? How do you explain that?
I think the biggest, and I don't want to be controversial. I think the biggest fact is people think healthcare is this noble profession, and the reality is it's a business, no different than any other business, and they are there to make a profit, and the less they spend on you, the more they get to keep.
Right.
And you have to remember that even if you go to the top institutions, they will direct you to their in-network doctors. They will do anything they can to enhance their profit, and hopefully take care of you too.
Yeah. That's pretty dark, doctor, but it's definitely the reality. Moving on to the second part of this interview, what's the relationship between jaw structure and sleep disordered breathing?
Um, well, I think the anatomy has a lot to do with sleep disorder breathing. Almost everyone with sleep disorder breathing has a malocclusion. Remember those? You probably are aware of it. Those monkey experiments by Harbaugh in the early '80s.
You tell us about them.
Oh, he took some. Monkeys are obligate nasal breathers. I don't know why they did this, but they took silicone plugs and they sewed their noses shut. And basically, what the monkeys did is they had to now breathe through their mouth, right? And some did this. Some did this. Some did this. Their jaw fell back, and some did this. And in the manner and how they decided to breathe, that's the type of malocclusion they developed: underbite, overbite, and open bite, and the ones that had the least deformities were the ones that breathed with their teeth closed.
Mm-hmm.
And then when they removed the plugs, things started going back to where they should be, right? And so, yeah, your jaws have 100%, linked to sleep disorder breathing. And it doesn't matter what bite you have. If it's a malocclusion, it's all that you should be wondering. And then but also you should be aware that it's more than just that. There's, like Apnea Med is working on a medication for sleep apnea. Should be probably the phase 3 trial should be released, the data next summer, and it should be approved in 26. But it's just working on the, like the loop gain. So there's other factors, like in slow wave sleep, a lot of times sleep disorder breathing disappears. It's normal flow. So it's more than just the anatomy, and you can, but you want to optimize the plumbing, but there are other factors involved too.
Is it true that sometimes there's a complete and utter disconnect between phenotype and symptoms, so that you might have a Brad Pitt or a Margot Robbie that might have sleep disordered breathing, someone with perfect jaws that has sleep disordered breathing, and vice versa, someone with small jaws that doesn't have sleep disordered breathing? So that, because I think the bias in my audience is to only think about the plumbing, right? But have you seen cases where there's really a complete disconnect between the plumbing and the symptoms?
Yes, it's I have seen those disconnects. It's not frequent. It's unusual, and sometimes we'll see someone with the most recessed facies, and we'll do a sleep study, and it's actually not. It's really not bad. It's just marginal, and that's why I tell patients, hey, it's not just one thing. And I don't want to digress, but the sleep study is just one part of it. Your physical exam is the other part of it. And I give a weight to all this. Like, how bad is your sleep study on a scale of 1 to 10? How bad is your exam on a scale of 1 to 10? How bad are your symptoms on a scale of 1 to 10? What's your rhinomanometry look like, the flow through your nose and resistance on a scale of 1 to 10? What's your brain map look like on a scale of 1 to 10? What's the tone in your mouth look like on a scale of 1 to 10? And frankly, if you have a cone beam CT, which we have, what's your cone beam CT look like on a scale of 1 to 10, right? And so we look at all of that. And so if you just have one thing that's like normal, like the sleep study, who cares if the other things are all abnormal?
Right.
So I think people focus too much on the perfect phenotype, but the sleep study is okay. Well, it could be other things that are,
Right.
I've seen people that are just flat out gorgeous, perfect looking on the outside, and behind their nose is completely deviated with enlarged turbinates. And
Mm-hmm. Mm-hmm. In medical school, someone currently going through medical school, or when you went through medical school, will they at any point on a single slide in all those years see any mention of the relationship between facial structure and the potential for sleep disordered breathing?
if it is, it'll be an individual instructor that does it.
Mm-hmm. So it's not part of their training that they see a patient that looks like Napoleon Dynamite, that's long face, down swung and back, mouth breathing, and they immediately think, okay, I need to perhaps question this person about the quality of their sleep. It's not at all part of contemporary medical training.
Yeah. I mean, part of it is we're very compartmentalized. Each doctor does their own specialty. And as you're aware, there's sleep disorder breathing patients in the psychiatry offices, in the neurology offices, in the diabetes offices, in every office, right? Chronic pain offices, fibromyalgia offices, you name it, right? And they're there. And so I guess the answer to your question is that where would that lecture be?
Exactly.
Because each lecture is so compartmentalized in med school.
Right, right. Do you happen to know Dr. Anna Lemke? I think she's at Stanford. She's a psychiatrist who got really popular on YouTube talking about addiction, and she's basically an addiction psychiatrist. But anyway, I reached out. I was going to say, if you knew her, I was going to ask you if you could ask her if she would come on my channel, because I reached out to her a while ago to see if she would come on so that we could talk about the relationship between airway, sleep disordered breathing, and addiction. But I they ignored me. So just trying to make that connection and
I don't know
get
her,
her
but
on.
I will see if I have a link to her email and I can maybe email her.
Yeah. And speaking of that, when are you going to go on to Andrew Huberman's podcast so that you can educate him on this subject? Because I think he's missing the point with a lot of this. He loves that guy, Matthew Walker, but
Yeah.
I think Matthew Walker doesn't talk much about airway and its relationship to sleep.
No, Matthew Walker is a brilliant guy, but I read his book, like everybody else, but I felt like at the end, okay, sleep will do this, it will do that. Bad sleep will do this, bad sleep will do that, and it'll hit everything and it scares the hell out of you. But what do? What's the
Right.
treatment?
Exactly.
And I think I'm also going to point out something else to your audience. It's not, we're all focused on sleep disorder breathing. Your questions are all on sleep disorder breathing, but really it's a breathing issue. It's an overall breathing issue. There's no ICD code 10 ICD-10 code for a small maxilla. So if you take two kids and you have a normal face and you take the other twin and you squeeze their maxilla and make it small, that kid's going to suffer whether or not they have sleep apnea at night. that kid's going to be anxious, may get, ADD-ish, ultimately depressed. And why? Because when you have that small maxilla, you're basically suffocating someone.
Right.
And you're in a fight or flight, high sympathetic tone, and and your body's used to being in that for a short amount of time when you sense danger and you run away and you sit under a tree and relax, and the fight or the rest and digest parasympathetic nervous system takes over. But if you have a small maxilla and you have to have that high sympathetic tone every day, every month, every year, every decade, it wears on you, and your body's not used to a chronic state of distress. And
Right.
it leads to all these problems. And it's very subtle. It's just like the theory behind braces: small forces over time can move teeth. Well, a small change in your anatomy can affect you higher up.
So why is it that we're in this paradigm where we only think of breathing problems as they occur at night while we're asleep, when in reality, people with small airways also suffer when they're awake?
Yeah, absolutely. 100%. So I tell people, hey, how's CPAP going to work? They'll ask me. I'll say, well, it should fix 90% of your nighttime breathing. It'll fix 0% of your daytime breathing.
Mm-hmm.
Well, how much better should I feel when I use CPAP? I say, well, if it fixes 90% of your nighttime breathing, then you'll get 30-40% benefit. But if it fixes 0% of your daytime, expect to feel 30-40% better on CPAP.
So, to your mind, what are the manifestations of poor daytime breathing?
I think high nasal resistance and reduced flow are like wearing ankle weights. It's like putting on a 10-pound ankle weights all day long.
Yeah, let's dive into this question of reduced flow. That's a term that only you use, as far as I've encountered. You did send an article, a PubMed article, that I think the point, and correct me if I'm wrong, the point of that article was that people with so-called reduced flow may have sleep apnea symptoms, even though they don't have sleep apnea. And so maybe we should consider reduced flow as a problem that's just as serious as sleep apnea because it's causing the same symptoms. That was my reading of it, at least. Uh, what is reduced flow, and what's the problem with it?
Well, it's I think it's elevated nasal resistance that consequently is reduced flow. When you have high resistance, low flow, and you have low resistance, high flow. It's actually it's a balance, right? You don't want too much, you don't want too little. Reduced flow isn't accurate. It should be normal flow,
Mm-hmm.
right? And so, have you heard of Bohr's principle? And
No.
when you, like, people ask me, my patients say, "Oh, why can't I breathe through my mouth? I get all the air I want," right? Well, in Bohr's principle, when you breathe or hyperventilate, you blow off CO2.
Right.
You get your CO2 levels drop. When your CO2 levels drop, the oxygen binds tighter to hemoglobin and it doesn't release to the tissues. So overbreathing is actually under oxygenating. It's counterintuitive.
Right.
And
I am aware of that.
yeah,
Yes.
and when you breathe through your nose, you actually you get all the benefits of the, obviously your laminar flow, the nitric oxide, the immunoglobulins, like sterilizing the air, and on and on and on. But if you have high nasal resistance, you're working for that air. It's still healthier than opening your mouth and breathing, but you're working for that air. And working for air, it's like someone coming behind you, Ron, and putting their hand over your face and suffocating you. What's the first thing you're going to do if someone does that? You're either going to
Freak out.
run or flight. You're either going to fight or flight. You're going to, and that's exactly what high nasal resistance is.
And the way we measure nasal resistance is with something you mentioned earlier, which is rhinomanometry. Can you tell us a little bit about rhinomanometry and who's actually doing that besides you?
I don't know anyone doing it. When they sold it to me, they said I'm the only only sleep doctor in North America that bought one. I said, really? That's absolutely ridiculous. I still think I hold that, I'll actually show it if I can have a little field trip.
Yeah, please, by all
Here's
means.
our rhinomanometry unit right here. And that's our brain mapping unit, but this is our rhino unit right here. You put a mask over your face. It's super simple. It takes almost, but what it does is it oh,
Yeah, I put you on the solo layout, doctor, so that you could
okay, yeah.
showcase that a little better.
Well, what it does is you put this over your nose, and then, but you plug one nostril and you put it over your nose, close your mouth, and you breathe through that nose. Then you do it with the other nostril. I don't know if I need to show anymore, and then you breathe 4 breaths, normal breaths, not extra, just normal breaths, right? And you get a tracing, and that tracing shows you what your resistance is, what your flow is, and we know roughly what normal is, and it's very objective. And I like to do it before allergy treatments, after allergy treatments, before palate expansion, after palate, before MMA, after MMA, but just in various scenarios. But there's 5 reasons why that rhino can be poor, and I think people don't necessarily recognize it. Number 1, tons of inflammation. The turbinates are just inflamed and huge, right? That can cause high resistance and low flow. The second reason is some type of anatomic deviation, like you've got a deviated septum, bone spur, something like that, right? The third reason is the entire maxilla is too small. And I know that because when we open the maxilla with expansion, it improves. And the fourth reason is a little more obscure. You're so recessed, your jaw is so recessed that it cuts the airway in the back that you don't breathe well through the nose. And then the fifth reason, which I don't have a good measure for this, and you probably never even considered it, is your respiratory muscles are weak. You can have an ALS patient who has no flow limitation at all, but has no air, just the volume is reduced. And that's because their respiratory muscles are weak. When you're a chronic mouth breather, you don't use your respiratory muscles as much. It's easy. There's no effort. When you breathe through your nose, you have to work a little bit, and it's a little bit of training, and you get stronger. That's why when I first put CPAP on some people, it's just overwhelming. What is this? I'm suffocating. It's too strong. And other people can handle it. To me, that's an indirect measure of your respiratory muscle strength, of what you can handle. And anyway, just some things to think about. So that's why when, the nice thing about rhinomanometry is patients will come to me, should I expand more? Well, let's repeat the rhino. Let's see where you're at.
Right. Interesting. And so I think that reduced flow is something that a lot of people in my audience have self-diagnosed. They can just feel that their nasal breathing is poor. But I've also talked to many people who told me they didn't even realize that they had poor nasal breathing until after they did expansion. And then their nasal breathing completely changed for the better. And they realized how constricted they had been the whole time. So, but could you comment on that?
100%.
Yeah.
People have no idea.
Yeah, right.
Every single day I show them, and even me, like I'm looking at you, you look great. You've been expanded, but who knows what your flow is like?
Right.
I mean, we have no idea. Just like the cone beam CT, I don't know what's behind you. Just like your brain map, I have no idea what your brain looks like. You look okay.
But, could be better. Could be better. I'm working on that.
The thing. I think it's very important because it's a free for all out there, the wild, wild west, as they say. But I think it's very important to be very data driven, and that we try our best. And we get the rhinomanometry in everyone. We do, we measure everyone's tone in their mouth with that IOPI. I can't find that thing right now. With the muscle tone, with the left lip, right lip, front tongue, back tongue. We measure everyone's brain with the brain map. We do a cone beam CT. We do this, whatever, some type of sleep study. And that's at least some data, right? And then that's a barometer. Hey, what's your brain map look like 3 months on CPAP? What's it look like after expansion? What's it look like after MMA? What's your rhino look like after all of these things? What's your tone now at the end of this? You look like an orangutan now. You've busted your face open, you're wide, everything is huge, but you still have sleep apnea. Well, what's your tone like? well, your tone is still low. So
Does the rhinomanometry inform what treatments might be more appropriate for one patient versus another? For example, and obviously the treatments we're focused on JawHacks are expansion procedures, jaw surgery and MARPE, more or less, but also soft tissue nasal surgeries. Does does the rhinomanometry score, for example, inform the question of whether or not someone could skip a MARPE and go right to double jaw surgery? In other words, does it tell you where the airway kink is? Are there different places where the airway is kinked? I know I just asked you like 10 questions all at once.
There's something. So general rhinomanometry is just pressure and flow. There's something called acoustic rhinometry, and that actually locates the place. But I didn't like it. The reason why I didn't do it is I just got my own cone beam CT, and I just feel like that just cuts to the chase, right? I don't have to infer. I can just see. And so the answer to the question is there is another, version of rhinomanometry called acoustic rhinometry that does exactly that. That doesn't do pressure and flow. It looks for location. But I find the cone beam CT far more helpful, which, by the way, the rep, at least in the West Coast, said I'm the only sleep doctor to have one.
That's bizarre. Wow. That's really telling, isn't it? That you're the only one with a cone beam CT. So that basically is saying that you're the only one who's really carefully looking at jaw structure in the bones of the face and the airway at the level of the bone.
I think you just have to have this curiosity, and that's it. Like, I got the rhinomanometry and I said, this is brilliant. And then once I got all these abnormal results, I said exactly what you said. Where in the heck's the problem? And I saw the acoustic rhinometry, but I didn't like that. I just wanted to see for myself, and I just haven't. It's just amazing. Anyway, so there's hope. I'm always looking out for other diagnostic modalities.
Right. Could you have a patient with high sleep apnea score or measurable sleep disordered breathing, but they don't have a lot of flow resistance, so that they might be more kinked in the pharyngeal airway? Or am I not understanding flow yet?
There are some examples of patients, just like you said, the completely recessed patient that has a negative sleep study. There are these patients, somehow they have okay flow and resistance, even though they look small, but it's few and far between.
Right.
And I don't understand it yet. I don't know how that happens.
Right. Yeah. So then, is there any data you can pull that can inform what treatment would be appropriate for a patient that has poor flow or bad sleep score?
Like sometimes what we do with the rhinomanometry is like, people put on those breathe right strips, intake breathing, whatever, mutes and all that stuff, right? And they'll say, wow, I breathe so much better, right? We'll do the rhino. It's like 50, 100 cc's per second better. But, they're still like 300-400 below where they should be, right? And so it's like, if they're at a small number and they go like that, it's huge to them, but they should be here.
Right.
So in that way, it informs me like, you got more to go.
Right. Sure. So then, just jumping into, I think, the heart of this interview, what is your approach to handing people off for actual treatment for their sleep disordered breathing? Like what's your logic tree to determine what treatments are appropriate?
That's up to the patient. So my goal is at the end of our visit to give them a list of all the things I think they need to do. And that depends. Some people are anti-surgery, as you're aware, and some people are very anti-medical. They don't want anything to do with the CPAP, right? And so so it just depends on what they want. A nose surgery is one and done. You don't need braces. You don't need any of that nonsense. Yada yada. Or an MMA can be one and done, but can they have the time off? Or do they have a job that doesn't allow them to take 2, 3, 4 weeks off, right?
Yeah.
So lifestyle, personality, all that plays a factor into what they want to do.
Right. jaw surgery and its effect on nasal breathing. Can you comment on what you've seen come out of your testing on that? I think there's a big question in the JawHacks community as to whether or not you can skip MARPI and go right to the double jaw surgery. What effect can double jaw surgery have on nasal breathing?
Oh, it improves it. I mean, here's the thing. It's Bernoulli's principle, right? Have you heard of that one?
Yes, I have.
That's where, like, if you increase the flow, just for your readers or subscribers,
Please.
if you increase the flow, like the speed of the air, the pressure along the walls of the tube decrease. But if the pressure on the outside of the wall is the same, that means it's going to collapse. Basically, the more you suck in, the more likely you're going to collapse, right?
Right.
And the thing is, if you have a restriction anywhere in your airway, like, it's going to cause the other airway to be under duress because you have to suck harder. And so what I'm saying is that you can go straight to MMA, but if you have high nasal resistance, it's going to cause that pharyngeal airway to want to collapse.
Right. Well, that's terrifying.
Yeah.
So where you land on the can I skip MARPI and go right to double jaw surgery question is that you'll get some benefit, but that the ideal max benefit comes from doing both?
I mean, listen, ideally you'd fix the nose, widen it, advance it. Like I think I mentioned this, your maxilla is like a box, it's rarely small in one dimension. It's short, but it's also set back, and it's not that tall with the high arched palate, at least effectively reducing the usable size. But what I tell patients is this: look, you cannot recreate what nature intended. That's the goal, and we can get you closer, but let's just get you to a point that is acceptable.
Mm-hmm.
That's it. So, and that's
it. Why can't we recreate what nature intended? Like with nasomaxillary expansion and a jaw surgery, where do we still come up short from what nature had intended? Is it the neurology where you're still sort of neurologically wired for that? You still have all that residual brain damage and the hangover from that, or is there more to it? Is there a plumbing aspect where we come up short too?
I mean, I think 100% the brain part is true. You definitely have to. There's no restoration. No one talks about it. It's not listed anywhere. It's not even mentioned anywhere about the brain.
Not even on, certainly not on JawHacks. It hasn't been mentioned.
Yes, and that's why maybe you can have an episode on brain hacks. Because I tell when I lecture to dentists and orthodontists and any other, I say, hey, you guys are all focused here, but you don't realize it. You don't realize it, and your subscribers don't realize it. But they're all focused 6 inches higher. That's what you're really targeting. If you weren't tired, if you weren't sleepy, if you weren't unfocused and depressed, and and all those things, you wouldn't care.
Yeah.
You know what I mean? So that's where it's impacting. So we just got to move a little higher. But why can't we recreate what nature intended? Because the entire face changes when you mouth breathe and whatnot. And these advancements are just partial. They just do a segment. They're not going all the way to the eyes and whatnot, right? Normally when you grow folly, the zygomatic bone goes up, you get high cheekbones, you get the feline eyes.
Right.
And even when we normalize everyone, I check my numbers. They're up there. They definitely get better, but they're not normal, right? So I guess your answer to your question is I don't know why exactly we can't, but it just doesn't. I think there's a danger of orthosomnia, and your subscriber. Have you heard of orthosomnia?
No.
There's different levels of anxiety. Just there's anxiety. I'm anxious, and maybe there's a panic attack or whatnot. The next level of anxiety is OCD, and that OCD can be something like religiousness, cleanliness, washing your hands, organization, or it could be something that's quote accepted by society, like you're cheap, right? A form of OCD, right? But and then the highest level of anxiety is paranoia. That's like, and usually, if some people who smoke pot, they get it. If you're schizophrenic, you don't need to smoke pot. You just have it, right? Like whatever, right? But OCD sleep exists also, and it's called orthosomnia. And so when I see a patient focused and focused and focused on sleep, I tell them you've got a pretty substantial anxiety disorder. And OCD is deep in the anterior cingulate gyrus. And you want to be careful because, you just have to be mindful. Is this becoming OCD at some point, or is OCD sleep?
Right. And is that essentially like is it like a trauma from fear of going to sleep, because you know that you're going to wake up feeling worse than you felt when you went to bed, and so there's just all this fear built up around actually going to bed, and so people start to obsess over it?
Yeah, even PTSD is a form of anxiety, but it is an anxiety. Like I'll tell my patients, I'll have someone that flies in on a jet. They come to see me. Who knows how much they're worth. They ask me for a discount. I tell them I'll give you a discount, but but I tell them what you should recognize is that you have OCD cheap. It's a mental illness that you have.
Yeah, how does
and,
that
and,
work? I've
and,
never
and,
I've
what-
never
and,
thought of cheapness as a mental illness, but
Yeah,
it,
because
it
society
seems right.
accepts it, and some cultures actually enhance it. Like say that's good to be cheap, right? But it is cheap. If you're worth this much and you're not willing to spend this much, that's cheap. That's a mental illness.
Some people would just say that that's the lifestyle that made them rich in the first place, but there's something deeper going on
No,
there.
at some point you need to let that go.
Right.
And just like the people wearing masks in a car, it's OCD germs. I'm just saying you can see it around you. If you want to know what's happening in this world, why we're all falling apart, there is a pandemic of mental health issues. Just turn on the news and look. You
Right.
got people like covered in, sitting in front of traffic, blocking it. You got people covered in oil, who knows what. I mean,
Wow.
it's all OCD.
Yeah. Interesting. And
But OCD sleep and the other thing about OCD, not that I don't know, I feel like I'm neurology. I feel like I treat so much mental health. I feel like I'm a pretty good psychiatrist. But anyway,
please have at it.
but the thing about OCD is there's OCD with insight and OCD without insight. So once I figure out if someone has OCD sleep, orthosomnia, I got to figure out, okay, do they have insight or not insight into this? You can't just tell someone, hey, you're cheap. It's an OCD mental illness. Rama, you're crazy. Or you know what? You're right. You know what? I am worth $1 billion, and I'm asking for $100 discount. You see what I'm saying? It's ridiculous at some point.
Yeah. So OCD with insight. Are you saying insight like insight meditation, like self-awareness?
No, like insight, like you're aware of it. Like it's crazy, but you do it anyway. Versus
right.
You don't even know it's crazy. You just think it's normal.
Wow.
So so we have to ask ourselves, Ron, are you OCD sleep? Am I OCD sleep? Do we have to always hey, temper this?
Yeah. No, now you've got me thinking about all the ways in which I'm OCD, and probably everyone who watches my channel is like, Ron, come on, we all know you're OCD, right? That's how you built this channel. But no, I never thought of that sort of fixation on something as potentially indicative of a deeper mental health issue. Does it sort of come from a place of like a scarcity mindset, like a lacking mindset, where people end up fixating, or what's the root cause of OCD, these OCD conditions?
I don't think it's natural for X percentage of our population to be depressed. I don't think it's natural for X percent of our population to be anxious, which is a form of anxiety, right? Or ADHD. Every kid has ADHD. Personally, I think it has to do with the breathing. I think it's an epidemic of breathing, not sleep apnea, breathing, leading to derangement of the brain.
Wow.
That's what I think it is. But I don't have any data for that. So, and I'm just too busy just treating people, right? Versus trying to figure out, just trying to prove one little thing would take like a couple of studies, as opposed to there's a bazillion things to prove.
Yeah. So on that point, are all sleep specialists neurologists? And if so, like, why is it that sleep specialists have to be neurologists? What's that all about?
No. Most sleep specialists are pulmonary critical care.
Mm,
Now, in the current landscape, because sleep medicine reimbursement is decreasing, you're seeing fewer pulmonary critical care doctors going into it because it's just not lucrative. And so what you're seeing now is more, at least now, more neurologists and psychiatrists and internal medicine doctors doing it because the pay differential isn't that different, right?
hmm, hmm. But neurology lends itself well to sleep medicine because just based on some of your YouTube videos, for example, I can see that there's a heavy neurological component to understanding how breathing affects the brain and the body at large. Is that right?
And I think so, but I can tell you nobody else really looks at this.
Hmm.
So I don't know. I'm out there like a shark in the ocean, swimming
Yeah.
by myself.
Yeah.
But
Yeah. Yeah.
I think honestly, I'd like to. I wish every one of your patients could have a brain map, could have rhinomanometry, could have muscle testing, could have a CBCT, which I'm sure some of them have had some of those things.
Yeah. Well, certainly most of my audience is at least diving deep into the plumbing deficiencies and is going to stop the bleeding, so to speak, by at some point committing to some sort of expansion. Um, and on that note, I wanted to ask you about your preferred type of nasomaxillary expansion. Do you have a preference as to Dr. Lee's ease procedure versus a regular old MSE versus a custom MARPI? What's the key to a well executed nasomaxillary expansion so as to benefit a sleep score?
I think listen, I think this is my opinion. I think in like I did an expansion for myself. My gosh, I think 7 years ago at the infancy of all this, and I think in 5-7 years from now we're gonna have a whole bunch of other options, right? So let's just keep that in mind.
No doubt.
But I think any expansion can have some collateral damage, and that collateral damage is asymmetry,
For sure.
and also damage to teeth and roots and whatnot potentially, right? At least at the high level. And anyway, but here's the thing. I think any expansion will improve your breathing. I know people foo-foo the V-shaped expansions, and I think for many reasons that's bad because you have to move the teeth a lot, and it's not natural. But you breathe so well through your nose with those V-shaped expansions. So you can't always knock them. And then the nice, steady, kind of even expansions are nice too. For me, this is my personal opinion. I think it's important to. I think for me, surgical assist is very important for any expansion because it reduces the asymmetry. I think opening that pterygomaxillary suture is very important. And so whenever these different expansion ideas come out, I always try to see what's expanding, right? Like what are they cutting? What are they moving? And I also think close follow-up, despite whatever expansion you do, is important. Like just repeat CBCTs to make sure it's symmetrically expanding. And if it's not, you can just stop and abort, assuming you're not going to get a jaw surgery that can potentially correct it later.
Right.
So I think for me, pterygomaxillary suture is probably the main. And just for your audience, I have my skull here.
Mm-hmm.
This is the maxilla, right? And then that's the sphenoid bone, and right there, that suture right there is the pterygomaxillary suture. And if you, because you don't want one to open and the other not to open, then you're going to get this asymmetrical expansion and whatnot, right?
You mean if the expander breaks one pterygomaxillary suture but not the other, that's what potentially might cause
Yeah,
one side to bump out more than the
yeah,
other?
yeah. And then if the expander is not in at a proper rotate like level, you can get a cant. I mean,
Yeah.
there's all sorts of stuff, right? And so, you know, an expansion is not easy, and I'm always nervous about that asymmetry.
Yeah.
But I tell
Yeah.
patients just stop it. If you get it, and this way it's minimal, right?
Yeah. Dr. Ting in San Diego, I don't know if you know him.
I've
Actually,
heard of
he's in
him.
Riverside County. He brought to my attention recently the role that the frontomaxillary suture plays in asymmetry, and he said that sometimes when you get that sort of stepwise drop in one half of the maxilla, where if you look at the front incisors and you can see one of them is just like below the other, that often happens when this suture breaks on one half but not on the other, and then the whole side just drops, and then you expand
I've
into
never
that
heard
drop.
that ever.
Yeah. And he showed me some scans, and after he showed me the scans, I was like, yeah, I've seen that many times in patients. In fact, it's
Now that
possible.
you mention it, I'm thinking about it, but I never realized it was due to this suture up here.
Yes.
That's
Yes.
fascinating. I gotta
Yes.
look at my own skull for that.
Right. Right.
That's
Yeah.
really interesting.
And apparently it's pretty common too. And my fear is that, um, well, I guess a lot of the guys I talk to are cranking really hard with reverse pull headgear, and they're just putting massive amounts of uh, force onto the pull. Like they'll rig up their own contraptions for like, I don't 100xing the force that you might get with a regular orthodontic elastic band. And I fear that they may be disrupting the wrong things and putting uneven pressure and then breaking sutures unevenly and contributing to asymmetry.
I mean, here's the thing. This is not real, but your skull is hard as a rock. I mean, it
Yeah.
is. It's, I could drop this thing. It's hard, and trying to do an expansion based on some thin bone here, and maybe the ease is a little better because it grabs onto the thicker part of the bone. But trying to use a small part of the bone to widen that entire skull is not easy.
Correct.
That's what you have to walk away with, and it's not easy.
Well, given that Dr. Lee is one of the few people who's actually releasing the pterygomaxillary suture, does that mean that that's potentially just objectively speaking the way to go?
I don't have any experience with the FME, the Mind. I have lots of experience with the MSC, the Dome, and the Ease, and I'll just say that I think the Ease has the least chance of the ones I've worked with that cause asymmetry. I've seen asymmetry with the Ease too, but it's infrequent. And so, but with the others, I've seen quite a bit of asymmetry. I'm sure you have with the MSC.
I experienced it myself.
Yeah,
So yeah,
exactly.
you can still see it in my bite. Look.
Yeah. Yeah. We look great, Ron, I think.
This is the side that didn't get expanded, and then this side
Yeah.
got knocked out and down.
Yeah, that might have been the pterygomaxillary suture.
Might have been.
Or this frontal suture, right?
It might have been. It might have been. Yeah, I don't know. I'm afraid to go back and look.
So, but hey, you're here now.
Well, it's like as long as some good can come out of my suffering, right? Then
I think your channel, I've been referring people to your channel. I'm like, go see JawHacks, whatnot. So, and so orthosomnia or not, or who knows what it is, well done. You have a great channel. I think it's a great service for people. And it's such a niche that it's helpful for me to refer my patients to your channel.
Well, I appreciate that. Do you think it would be interesting to collect data on rhinomanometry scores before and after various types of MARPs? Have you done that at all? Do you have any anecdotal sort of hunch as to?
Here's a tough thing about that, and because like I've seen tons of expansions, and I do the cone beam CTs. You know what happens if you go into an expansion with inflamed turbinates, like enlarged inferior nasal turbinates, they just expand and take up the new space.
Why?
So you can't. In other words, you can't necessarily compare the results because there could be the turbinates just getting bigger. So I tell patients before, and this is good for your subscribers, before you go do an expansion, make sure you control those turbinates. Otherwise, you're wasting your time.
How is that done?
Well, I do what I tell my patients at least is I do 2-3 months of Astapro, which is an antihistamine spray. I do 2-3 months of Flonase, and I do extra strength Simply Saline, 3% hypertonic solution, right? Just spray. I do all day long, and then we repeat the cone beam CT. We see if it's still large, I send them for radiofrequency, reduction in the office, and then I'll send them off to expansion. Otherwise, I mean, they can do that at any point, but the point is you need to keep those turbinates small.
Yeah, but how do we get to the root cause of what's causing them to constantly get enlarged? What is causing turbinates to get enlarged?
Yeah, it's an inflammation due to an allergic reaction, but we don't know. You go to the allergist, they can test for one out of a gazillion things that are out there,
Right.
and so most things we don't know. Just accept it.
Right. And so you've seen though that no matter, even if you get a 1 centimeter nasomaxillary expansion, right? The turbinates will just take that new space and just occupy it.
Oh, almost a. I mean, almost 100%. I mean, I won't give a number just based upon my anecdotal viewing of it. Absolutely.
Bastards.
Yeah. So it's penny wise, pound foolish. Maybe I don't know. Or not even that. It's just short sighted.
Right. And does the ablation, is that what the radio frequency is? It's an
Yeah.
ablation. Does that don't they often re-enlarge after that too?
Oh, it takes a few years.
So you just constantly have to mow the lawn with the turbinates and just
Well,
keep.
no, you don't want to hit the outside of it. You don't want to. The turbinates have a function. It produces a laminar flow. It dehydrates. It humidifies the air. Dehumidifies it. But but the radio frequency, it goes under the mucosa, over the bone, and burns it, and then it shrinks from the outside in, so you maintain the patency. You got to find someone that's done it a lot,
But
not just someone that says, "I got one in the back, I'll dust it off and bring it out."
yeah, no, you definitely don't want to do that with a MSE or with a jaw surgery either. Right? You want the person who's doing those all the time. But I guess what I'm asking is, do you do a turbinate reduction like that with the expectation that you're going to have to redo it in 5 or 6 years? Or once you establish a proper nasal breathing habit, can that sometimes eliminate the root cause of what's causing the turbinates to get inflamed, and maybe you never have to do it again?
Great questions. Absolutely. I think use it or lose it. If you don't use your nose, everything just gets inflamed in there and whatnot.
So you mix the turbinate reduction with the nasomaxillary expansion to buy you time to establish those habits, to keep, like, you tamp it back to the point that you can keep it tamped back, so to speak.
And you don't need to reduce the turbinates before. I'm just saying that why wouldn't you do that?
I think people just fear the empty nose syndrome thing. How do you feel about
Not
that?
with radio frequency. I mean, I've never seen it with radio frequency.
Do you see people getting good results just by doing only turbinate reductions and septoplasties? What are your thoughts on taking a soft tissue nasal surgery only approach?
Yeah, it depends how bad it is. That's what I said. We're not going to recreate entirely what nature intended. Just how far do we need to go to where it's acceptable?
Yeah. What about jaw surgery? Like, how do you vet a jaw surgeon to make sure that you're getting a good outcome?
I think now that I have my cone beam CT, I don't go by reputation. I just go by before and afters. I need to see it. And so I've had some nose surgeons that I haven't been really impressed with their work that have good reputations, and and you don't know, right, until you scan them. So anyway, I think that's how I would vet it, is someone that does it frequently, and I've seen some before and afters, and yeah.
You've seen before and after scans, not before and after photos. Is that what you mean?
Before and after scans, yeah.
And how do you get access to that information?
Oh no, they come see me for whatever reason. I don't see it before, but I see the after at least. And I'll say,
you look at the scans of your patients before and after their jaw surgery, and so you sort of have inside information.
Yeah, or I'll, even if I see them after the fact, they've had one, I can see the post. Like, I had surgery with Dr. So-and-so 10 years ago. I'll do it. Let's go cone beam. Oh, that looks good.
Yeah. And what do you look for on a scan that tells you that a jaw surgery was well done?
Oh, I'm looking at the posterior pharyngeal space. That's the main thing I'm looking at, right? Does it look like it's, like, I know the radiologist will say 100 millimeters squared is the minimum amount that's necessary, but I tell the average person at least 200, but if you've had jaw surgery, I want 300-400.
And what metric is that? Is that a slice of the surface area of the narrowest
Yeah,
part of your
the
pharyngeal
narrowest
airway?
part. The radiologist will only say 100 millimeters squared or less is abnormal. So 10 by 10 or 20 by 5 or whatever, right? What's fascinating about the cone beam CT, now that we do it, some people have like an hourglass airway like this. I really feel bad for them, because but then other people have kind of like a straight airway, but some people have a really wide airway, but really narrow, right? Like just very thin.
Like wide
So,
like this, but narrow like
yes,
this?
exactly. So they would do really well with the oral appliance or jaw surgery, right? I do wonder, no one's ever talked about this, but what happens to those people with this hourglass airway? Would they do well?
Yeah.
You
What
know,
is
with,
that? Is that just the shape of their esophagus?
I mean, a lot of times when I see it like this, the first thing I look for is tonsils to see if the tonsils are encroaching and making that. And I keep my
Mhm.
fingers crossed with the radiologist because I send everyone every CBCT I do, I send to a high-end radiologist, and they look at every tonsil, uh, the adenoids, the palatine tonsils, and the lingual tonsils, and I keep my fingers crossed that it's enlarged, because then hopefully we can make it wider, right?
Because otherwise they're just an anatomical abnormality that's
Well,
kind
if
of just
it's like
screwed.
this, what I worry about if it's really an hourglass, if you do an oral appliance, I could actually further crush that airway. Or
Wow.
what if a jaw surgery, will that help someone who's an hourglass? So when you get your jaw surgeons on, and I know you have a few of them on there, ask them, do these hourglass airways do well with jaw surgery?
What percentage of sleep disordered breathing patients might present with that hourglass
20,
airway?
30%.
Gosh,
Yes, a lot.
man.
And so if you had that, maybe the right thing to do is, if there's tonsils there, you take those out first and make it like at least a little bit like that. Then you do the advance. I don't know, throwing that
Yeah,
out.
yeah, right. So, but for, your everyday patient who has no access to a library of records of any given surgeons before and afters and no ability to really, analyze a cone beam scan, how do they choose a jaw surgeon? Or, I mean, you know what I mean? Because I feel like the landscape right now for jaw surgeons, and the number one question I'm getting that I don't have an answer to is, who should I have do my jaw surgery? This person, that person, that person. Because it's like we're in this weird situation where we're all just passing around the same, um, reviews of any surgeon. Oh, this person is supposedly really good. And then I hear that, and then I pass that on to the next guy. And then it comes around back full circle to me and reinforces the idea, oh, that's the guy. But
Yeah.
then you go to another surgeon, and this other surgeon is saying, oh, I've done lots of revisions from that person. My surgery is the best. And then it's like, oh, maybe this person is the best. And we're all just, you know, playing phone tag with reputations of surgeons. And I don't feel like it's productive.
Yeah.
And I just don't know what the way out of this is.
Yeah. I accompanied a patient once, and I saw Dr. Lee I mean, I know Dr. Lee well, but anyway, I saw Dr. Lee. He wanted to see Dr. Gunson. So we met Dr. Gunson, and we met Dr. Wallin down at LA Comms, right? And I can tell you, it's fascinating going through those three. I accompanied the patient. It was fascinating because I walked away thinking, how in the hell does a patient make a decision? Because the information he got from each location just makes your head spin. Then we saw a fourth doctor, and that person gave a completely different. And I was just like, my God, you. So I don't have an answer to that.
There was no consensus among the four surgeons. Like,
There was
okay,
no
these,
consensus. 4
with,
millimeters, 14 millimeters,
come on.
millimeters, 8 millimeters.
No, really. They were all presenting different movements that they were recommending.
Yeah, but I mean, they all had their reasons for it, and they all kind of made, to some sense, right? But it's like it's fascinating. It's just interesting.
Yeah.
So what I've come down to is this, Ron, and you're gonna think it's nuts, right? I've come full circle. I've done this for 20 some years, right? I tell people, go in, do the procedure that makes you look the best. Make it 100% aesthetic and look like a king or a queen. And they say, why is that? I say, because I've seen people look like orangutans show up in my office and they still got sleep apnea. Okay. So, number one, it may not even work. Right? Number
Oh
one.
my gosh, that's
Number
awful.
two, at least you look good. At least you got that looking glass self. If people think you look good, you're going to look good. You got that mental part going, right? And and I say, and even if they under advanced you because you look good, it's better than what you had. You are closer to what nature intended.
Right.
So that's my recommendation now, because I tell patients it's not, no device, no contraption, no, nothing is gonna, nothing trumps your own biology. Lips closed, teeth together, tongue on the roof of the mouth. That's going to beat any of this other stuff. So just go in there, don't over expand and look like a clown. Don't over advance and look like an orangutan. Don't rotor root and get empty nose syndrome. Just do what you need to do and look good, and you're done.
Yeah, the middle way. But then this gets us to the next question, which is how do you know which surgeon is going to give you the best aesthetic result?
Oh, that's just comes down to, you have to find a good doctor to work with, and then, like in my community, at least in this area, I know who. It takes a while to generate this. It takes a few years to know who does what.
Right.
Like I have a person I use for functional nose. I've got a person I use for aesthetic nose. I've got a person I use, whatever, right, for different things, right?
Yeah. Well, then are you saying though that the biggest risk for getting a poor aesthetic outcome with jaw surgery is an over advancement?
100%.
Yeah. Can you speak on that a little bit? How does this, why would a surgeon over advance out of hope that they might cure sleep apnea?
No, because patients, that's not their fault. Patients, they usually, surgeons give multiple plans, and patients will come in there with their orthosomnia. I want to do everything. I could care less about aesthetics. I want my jaw. I want most airway. Airway, airway, airway. What are you going to do? You're going to give that person the airway, right?
Yeah. Do you think though that that when you that there's an equally bad problem, which is under advancement too? How do you strike the balance between over advancement and under advancement? Because what I'm hearing most of is complaints about being
Yeah.
under advanced and
Yeah.
not getting that
I
airway
wouldn't, I wouldn't,
solution.
I wouldn't even recommend anyone go into surgery if they're not going to do at a minimum 8 millimeters.
When you say 8 millimeters, what do you mean by that?
3 here, 8 here, something like that to
Yeah,
counter. Some, depending on what they need, right?
with the rotation.
Yeah, but that's the minimum. Like, so in other words, and maximum, I tell people maximum 12. I don't want them to look bad.
Yeah, yeah. So there's this. Someone said to me recently, there's two types of jaw surgeons. There's jaw surgeons who focus on treating sleep disordered breathing, and then there's jaw surgeons that are aesthetics focused. So, for example, I don't know if you've heard of Mirko Raffaini in Italy, but he's got this. He's an older gentleman. He's got this amazing Instagram page where he turns, people from basically being ugly to being supermodels, and they're striking. And yeah, of course, we're getting the best of the results are being put on his page. But someone saw him recently who came back and told me about the experience. And this was an airway patient. Obviously, he had a lot of sleep disordered breathing. And when he asked Dr. Raffaini, will this help my sleep disordered breathing? Dr. Raffaini kind of like didn't even really want to talk about sleep apnea. It wasn't even really on his radar. He was just sort of like, yeah, it should help, but that's not really how I think about it. I only think about the aesthetics of this. So is it the case that some surgeons are sort of into cosmetic enhancement and then others are more focused on getting a sleep result? Or is it just, a rose by any other name smells as sweet? Is this only semantics, or are they actually doing different movements to cater to their bias?
I think the latter. I think honestly, like, if you function and form go together, so if you look good, you should function well.
Mhm.
But you can overdo the advancement. Does that make sense? Or
Yeah.
underdo the advancement. But underdoing it shouldn't look good either. Overdoing for, in what sense? In terms of airway or in terms of aesthetics, right? So I think if you optimize the aesthetics, you should have enough airway. That's my opinion now after all these years. You should have enough airway. Now the rest of it's hard work. Get your tone up. Become like that's why I have like a lion, hanging. I'm big into these lion murals, because they're muscular everywhere, but also in their entire mouth they're like extremely muscular, right? And so I just say, if your face is in balance, then you should be okay.
Yeah.
You should have enough airway. I'm guessing if I scan that doctor's scans before and after, maybe it's not huge, but I'm sure he added a couple 100 millimeters. I'm guessing.
Yeah.
I don't know.
Yeah. Yeah. That's actually very insightful, and you're the first person I've ever heard offer that perspective. So I think now I'm sort of getting to an answer on this as well, which is, yeah, I think you're right. There's so many other factors that go into having a functional airway besides just the space. And maybe if, if you're Vegas, the way you approach jaw surgery is you just aim for the perfect aesthetic result, and then you
Mm-hmm.
let the cards fall where they fall after that, and you rely on yourself to do the hard work to get
Mm-hmm.
you the rest.
Yes, you're just providing the support and the structure, and the rest of it is on you.
Yeah, but you do concede that there's no way of having 100% certainty and confidence going into a jaw surgery that it's going to be a perfect outcome. There is always going to be this element of sort of taking a leap of faith.
Yeah, but yeah, I just, but yeah, I do, But I think as long as you go to someone that's done a lot and they have a good reputation afterwards, that's the problem. It's not transparent.
Mm.
Like, with my work, you can see the reviews, you can talk to people who've seen me like you have, right? But some of these doctors, you don't get that feedback. They don't put pictures on their website and whatnot.
Yeah. Do you have a sort of a pantheon of jaw surgeons that you like, maybe 5 of them that you like, or 3 of them that you like, that you would be willing to share their
Um,
names?
well, I mean, I'm in the Bay Area, so I've been using Dr. Lee a lot. I've been using Dr. Bowie at the Kaiser Permanente system, Peter Bowie. I like his work. I mean, these are you haven't really heard of him, right?
I've
And
never heard of Dr. Peter Bowie. No, that's a
yeah, but
completely new one.
he's in the Kaiser system, right? But it's an internal HMO system, right? That's pretty big out here in California. Um, if someone wants purely aesthetics, I've been using Dr. Gunson. Like if they just want that, the fillers and the whole, like, and as much of that. And then there's a couple other people I use that are not as well known. I don't want to mention their names, but they go through insurance, and some of these patients want to go through insurance.
Yeah.
And they're good, but they're not. They do other things, right? But they do good work. I've seen good outcomes from them. But they tend to want to do single jaw surgery. You can tell when someone isn't as proficient. They lean away from doing both jaws.
Yeah. What they'll do, the lower jaw, you mean, by itself, because it's a little easier?
Yeah, they'll pull 2 teeth out. They'll retract the teeth and pull the lower jaw forward, and then it depends where the obstruction is.
That's kind of like a compromise surgery for someone who must have it done by, under insurance coverage.
Or it just is, like I said, you go to even the top doctors, you're going to get different recommendations.
Yeah. Yeah. And the fact that Dr. Lee is doing other things besides just jaw surgery, that's not a factor. He's done countless double jaw surgeries. To your mind, he's part of the Mount Rushmore of jaw surgeons.
Well, I mean, look, planning my daughter to have jaw surgery, I'm choosing Dr. Lee because I've known him. He does good work. And if I didn't choose Dr. Lee, I'd probably choose Dr. Bowie.
No kidding.
That's who I'm picking for my daughter, right?
Mm-hmm.
But would I have an issue with the others? No, but I'm here in Northern Cal. I work with them, and so.
Yeah. Yeah. Have you considered jaw surgery for yourself, or have you had jaw surgery?
I had jaw surgery. I won't say with who, but I was disappointed with it, and I won't say who.
Yeah, I won't ask you. But what were you disappointed with?
I was disappointed because it left me with my right tongue numb. It still feels like lightning going across my lip. I can't feel my gums. Um, and then the associated procedure, it left 2 dead teeth in the front. And then the genio was cut too high. So the roots of the bottom teeth are now shortened because the genio was cut too high. It left me with
Jesus.
a large gap, about 9 by 3 millimeters of no bone in between my upper teeth on the top, almost like a nasal palatine cyst, but it's not a cyst, it's just lack of bone growth. Um, and yeah, and some asymmetry too.
And are these things that's a lot, man. Was all of that just due to lack of surgical skill,
Yep.
or
And I think part of it was the dome, right? And then part of it was lack of surgical skill. But I learned from it, right? And but at that time the ease wasn't even ready yet. Does that make sense? I mean, I was so
yeah,
early. I was just early and whatever,
I
right?
was too.
And I got sucked in with the reputation and the degree and all that stuff. And
Hmm.
I don't think I chose wisely. But I'm here to help my patients now, so it's all good. And and I'll say this one: despite having gone through all that, if you told me right now that's the only path I'm allowed to take and do it again, I would do it again.
You mean what you did is better than nothing?
I feel good, but I just wish I didn't have all this collateral damage.
Yeah. Yeah. Wow. Well, it's thank you for sharing that. I mean, that was very vulnerable of you to share that. Um,
All right.
I think a big problem in this community is that people don't share when things go wrong, and so we get a lot of um, positive bias toward a treatment or toward a provider because patients go into hiding when something goes wrong, and then we never hear from them coming out the other end. That's a big problem with me and with my network. My referral network is that I don't see a lot of people coming out the other end of treatments. I only see them on the way in because when they finish, they don't need me anymore to talk about things. They're done, and so I don't hear a lot about
Mm.
how things turned out.
That's why I got to add a little brain hacks mini segment afterwards.
Yeah, yeah. What do you mean? Like I should
Like,
follow up with
hey,
people
like,
more?
are your symptoms better?
Yeah, I think I could use my channel somehow to collect more data, but I just don't know what that would look
Yeah.
like. I
Yeah.
should figure that out. Some sort of form that people can fill out that where they report how things turned out. A questionnaire that helps gather some of the brain data.
Yeah. Yeah. Very utilitarian then.
Yeah, yeah. Um, Doctor, let me just scan my questions here. I did have some questions come in from my Discord for you. Um, we probably already discussed this to some degree, but without the right language, could you just distinguish between UARS and sleep apnea?
Well, there is no more UARS. In the International Classification of Sleep Disorders, UARS has been removed as a diagnosis. It's all obstructive sleep apnea. But historically, it's very simple.
Hmm.
AHI less than 5, RDI greater than 5 is UARS.
It's that simple.
It's that simple.
So, what do you think about this sort of tagline that, oh, UARS is sleep apnea for the young and fit? Is there any truth to that?
Yeah, because they get more arousals than DSATs.
Right, right. Um, I wanted to ask you about this. So, my orthodontist Ilya Lipkin told me this story, and you to comment on, how you would approach a problem like this or avoid this situation. He had this patient that uh, he was having terrible sleep, but then when he would go out to do the sleep studies, he would constantly have the best night's sleep of his life every time he did the sleep study. And no one could figure out what was going on. Why was he sleeping terrible at home? But then when he would go to these labs and he did 3 or 4 different sleep studies, he uh, had a great result. And then what they ultimately discovered was that this guy was being woken up by his wife who was tossing and turning. And then when he was in the lab, there was no wife that was disrupting his sleep. So he was getting better sleep. Like there's all these factors involved in sleep. How do you account for all of that when you're trying to understand what's going on with the patient?
Um, In terms of sleep study?
Yeah, in terms of doing sleep studies.
Well, we do it in the home or the hotel, right? So,
Hmm.
we do it but they have to be in the area. So we actually capture what's happening at the home. So it's the opposite. Most people sleep better in their own home versus the lab.
Right.
Different bed, different temperature, humidity, all that stuff, light, noise. Um, so I think we capture them in a pretty natural setting. So that's what we do. I don't know what other people do. But people with insomnia typically sleep better away from their home. But so that. But then again, yeah, that's probably the one downside of what we do.
Hmm.
Sometimes if you take someone out of their environment, they sleep better.
Yeah. Why is that? What's up with insomnia and you being at home? Is it just like an anxiety related to your
Like it's an
normal environment?
association.
Yeah, an
Like, oh, there's my
association.
bed. I don't sleep. I don't sleep in bed. And then, oh, but you go to a different room, you don't have that negative association.
Yeah, that's bizarre. Sometimes when I wake up in the middle of the night and then I go somewhere else to lie down, like it could be a super uncomfortable surface, like a sofa that's too small and my legs are hanging off the side of it, but I'll fall right to sleep even though I've been tossing and turning for an
Yeah.
hour in my perfectly comfortable bed.
Yeah, exactly.
It's
Same
kind of
theory.
bizarre. What do you think about the relationship between TMJ health and sleep disordered breathing? Do you think sleep disordered breathing can cause TMJ disorders via the bruxism connection, like where you're clenching and then that's an overuse injury of the joints?
Well, this is my thought, right? Any sleep disorder breathing, what happens? Remember, any breathing problem causes a malocclusion. Not sleep disorder breathing, any breathing problem, daytime breathing causes a malocclusion. Remember the monkey story, the
Yeah,
Harvard?
yeah,
And so at night, sleep disorder breathing can your your body clenches. This is my theory, and I think I'm pretty accurate because I always see CPAP reduces bruxism, right? But what I believe is happening is your body's trying to tone your tongue to get it out of the way, but it can't tone it directly like you can like during the day. It's no problem, right? But at night it clenches. It's like doing a pull-up rather than doing a straight pull-up. You're jerking your whole body, trying to get your body up, right? You're grinding, you're clenching, trying to tone the tongue, but in the meantime you're hurting the jaw joints. But the jaw joints are already under strain from your malocclusion, from your bad breathing, from development.
wow. Yeah, so you would agree that there is a connection there. And
Yeah, but it goes before that.
yeah, it's not, yeah, it's complex.
It's yeah,
Um, That's scary. And so, do you think, though, that an integral part of treating TMJ disorders is to eliminate sleep disordered breathing or to look?
absolutely,
Yeah.
100%. I work with a huge group in Indiana called TMJ Sleep and whatever, right? And they're the only group I know, but they do about 50 to 100 sleep studies a month. They do a lot. They're checking every single patient, but most TMJ people don't.
Right. Right. Um, so, then what are your thoughts on mandibular advancement devices that are, I guess you could say, they provide some TMJ disorder relief, but also pull the mandible forward out of the airway? Is that ever something you prescribe or suggest to patients?
I tell them long term it can move your teeth and hurt your jaws. I look at their CBCT. If it's like this, I say it's probably not the best for you. If it's like this, it can help. What do I think? If you wear CPAP and you want it as an adjunct for a weekend or a getaway, great. You can use it forever, sporadically, right?
Yeah.
Yeah. But that's what I think. If you're a CPAP person, I think you should have an oral appliance as a kind of like a get out of jail free for a night card.
Mm-hmm. Mm-hmm. And what are your thoughts on various self-diagnosis approaches for figuring out if someone who wants to try to self-diagnose their sleep disordered breathing? What do you think about like the Snore Lab app? Just measuring whether or not you snore, is that useful?
Yeah. I think, I tell patients pick whatever barometer you want. Like you choose Fitbit, Aura Ring, Snore Lab. I haven't really heard of that one. I mean, I heard of it, but I don't know much about it.
Yeah.
Um, and now you can even use the Muse. It has a nice, at least it checks the EEG. There's actually a great one coming out. You can pre-order it. Elamind, ELE MIND, I believe it's called. And it's all EEG based and stimulates and whatnot, but it'll also track your sleep too.
Mm-hmm.
But I'm trying to find that. But anyway, those are the things that I think. Yeah, ELEMIND.com. Elemind.
Mm-hmm. Is that something you're investing in?
No, zero, nothing. I don't have any investment. I'm only part of Full Power, which is not even available to buy. It's a product that goes under the bed. That's what I use. Um, and then I'm working with the company for a positional sleep device. But I don't have any. I have nothing linked to anything. I'm 100% authentic. But I can
Yeah.
show you my sleep tracker. What's nice about my sleep tracker is it'll actually tell you an AHI. Um, it's not available though, but you see I was 2.9 last night, and then let me swipe. Then I was 4.8 the night before.
Yeah.
Two.
Could put that in the center of the frame, doctor, please?
Oh yeah, put it in the center frame. 4.7, 3.6. I just love having but you see how it varies from night. But I'm usually normal, right?
How is that thing determining an AHI?
It's all AI.
Yeah.
But it tells me my respiratory rate, my heart rate, my staging of my sleep.
It's an algorithm, essentially. It's
It's an
pulling.
algorithm, but it's not perfect, but I can use it to track. You know, it's interesting. If I gain 5 pounds, which is nothing, 147 to 152, my the numbers go up. It's fascinating.
Wow.
It doesn't
Wow.
take much at all.
And is that even 5 pounds of muscle, or would that just be 5 pounds of
I mean,
fat?
I vary 5 pounds, just within a range of 5 pounds, but I'm realizing, hey, so I notice it. So it's helpful.
Yeah, totally. And what app is that
That's
you're
not
using?
available. It's not
Oh,
available.
okay.
That's what I'm saying. You asked me if I'm linked to the other company. No, but Elemind, what I like about them, is a group out of MIT, and they did some good research on neuromodulation, and they're finally coming out with their product. I think it looks interesting.
Yeah, that's very exciting.
Remember, I'm brain.
Right, right. That's good. Well, doctor, we're approaching 2 hours. I want to be respectful of your time. I'm really grateful that you came on. I learned a ton. I'm sure everyone else is going to learn a ton. Before I let you go, would you be willing to connect me with Dr. Gunson, potentially, to have him on for an interview?
Yeah, sure. Absolutely.
I've been dying to get him on. I really respect him and his work, and I think it would be, great if I could get him on. And I know that you know him well, so wanted
Yeah,
to put
I'll
you
reach
on the
out.
spot.
Yeah, I'll reach out to him.
All right, doctor. Thank you so much, and we'll be in touch.
Okay. Thanks, Ron. Have a
All
good.
right. Take
Bye.
care, doctor. Bye bye.